Okay, good morning. Welcome to day 4. Morning. So hopefully more people will join. So today we'll start with 2 short talks. So first speaker is Herbert Corredor from Emory University. He's going to speak about AI-driven computational pathology. Herman, please.
Okay, can you hear me okay there?
Yes, we can.
Okay, good morning. Thank you for the invitation. It's an honor being part of this workshop, even remotely. My name is Germán Corredor. I'm an assistant professor at Emory University, and well, I will present this today. I'd like to start this presentation with this question: can AI help better treat cancer? On developing AI-based techniques to help physicians to make decisions related to the treatment of patients with cancer. This is the agenda for today's presentation, so let's start. Let's start by answering this: why AI? So currently we have something called a histopathological analysis that is the gold standard for diagnosis of most cancers. So in this analysis, pathologists look at tissue samples extracted from patients, for example, from a tumor or a suspicious mass, and they look at different structures within the tissue. They look at the cellular architecture, the organization, the colors, the shapes, and several other visual features, trying to provide a diagnosis. Basically, they are trying to find what's going on with the patient.
Herman.
Yes.
I think we have a fire alarm. One second.
Yeah, sure.
Okay, let's go to the take 2. All yours.
Okay, so I was saying that we have the histopathological analysis that helps pathologists to look at to look at the samples, the tissue samples from patients, and analyze them to provide a diagnosis. Pathologists are very good at these tasks. They are excellent at giving diagnosis, but they have to face several challenges. So one challenge, an important challenge, is that human perception can be easily deceived. So this is an interesting example. I hope from the distance to the screen you can see the effect. So if you can see this correctly, you should see like a Coca-Cola can, but it looks like red. But actually, if we do a close-up, we can see that there is no color red. It's just like what our brain is making up. It's actually white. Another challenge is that there is a high discordance between humans when they are estimating quantities. For example, if we ask a group of pathologists to estimate how many cells of this type they can see in this specific region, it's very likely they will give very different numbers. And finally, predicting the future is not an easy task. In this case, when I'm talking about predicting the future, is knowing what's going to happen to the patient. It's very hard to tell from like a patient with a diagnosis if it's going to die of the disease, it's going to have recurrence after treatment, is the tumor going to respond to the treatment, and so on. So there are different things that are uncertain for pathologists, even if they have the correct diagnosis. So this is the reason why computers can help us. There are different ways. So one of them is by providing an objective quantification of structures, identifying structures or regions of interest, and also for grading diseases, for example. Also, computers can help us in predicting the likelihood of recurrence of death. And finally, they can also help in predicting the response to treatment. So let's take a look at computational pathology and its capabilities. So for like before computational pathology, or like how everything started, it's with digital pathology. So in a very like brief way, digital pathology is the digitization of glass slides so they can be seen in a computer. So these are the same glass slides that pathologists use for their analysis, but the advantage of having them digitized means that we can use computer algorithms to analyze them. And this is how we get to computational pathology. That is nothing but mining information from digitized pathology slides. So for now, I'm going to present some examples of biomarkers that we have developed in our lab using the capabilities of AI and image processing. So first, I'm going to show you some biomarkers based on cellular morphology and architecture. Oncotype DX is a well-known molecular test for predicting likelihood of recurrence in breast cancer. The problem is that Oncotype DX is expensive, is tissue destructive, it's time-consuming. So we were wondering if we were able to do something similar, like a similar prediction of Oncotype DX, but using only morphology. So we use information from cellular shape and cellular architecture, and we were able to predict the different oncotype DX categories for ER positive breast cancer. More recently, we tried a different approach in which we were trying to extract features from nuclear shape, nuclear architecture, tubules, and mitosis from samples from patients with breast cancer. And we were able to find that features from these different categories were highly correlated with patient prognosis. So we had a large data set. We trained our models on part of this data set, and we validated in a totally independent data set. More specifically, we used the ECOG 2197 data set for this independent validation, and we were able to show that features are able to differentiate between patients who are at high and low risk of recurrence in breast cancer. We also have developed some biomarkers based on multinucleations. So very briefly, multinucleation is a cell with multiple nuclei, and usually they are correlated with more aggressive cancer, and thereby it's related to worse prognosis. The issue is that finding the multinucleations and quantifying them is not an easy task for humans. So it's time consuming. There are not like well-defined like guidelines for quantifying them. And for this reason, we use a combination of artificial intelligence, more specifically deep learning and image processing, trying to detect automatically these multinucleations. And then we created something called the MUNI, or the multinucleation index, that is nothing but a ratio between the total number of multinucleations divided by the total number of epithelial cells. And we validated this approach in a large data set of patients with HPV positive oropharyngeal cancer. And again, these metric, only based on how many multinucleations the patient had, was able to differentiate patients who are at high and low risk of recurrence, which is very useful for clinicians to make decisions. If they know these patients are going to have better prognosis, they can be directed to like a less aggressive treatment, for example, and patients at high risk can be directed to like standard or even more aggressive treatments. We also have worked on biomarkers based on tumor infiltrating lymphocytes. So tumor-infiltrating lymphocytes have shown like prognostic value in the past. The problem, similar to multinucleation, is that the quantification is time-consuming and it's hard for humans to come up with an objective metric for this. And they also, so most studies have focused only on density of lymphocytes, but they haven't checked the architecture of lymphocytes. So that's why we developed an AI-enabled model to create some heat maps of density of lymphocytes, and we found that these maps were correlated with benefit of radiotherapy in breast cancer. Well, this is ductal carcinoma in situ that is like pre-cancer, a pre-cancer stage. And in general, what we found is that higher levels of TILs are more likely to or are correlated with benefit of radiotherapy. And similarly, we created an approach based on a spatial architecture of TILs. So the idea is not only about how many TILs or what's the density of TILs that you have. It may be more about how they are organized and how they are infiltrating and interact with other cells. So we created this approach to characterize this architecture and interaction. And we found it prognostic for triple negative breast cancer, as we can see in the example here, but also for other cancers. And finally, I want to show this biomarker based on collagen fiber orientation. So for this, we use image processing to find automatically the collagen fibers, and then we created a sort of a matrix trying to model or represent the orientation of the collagen fibers in different regions of the image. So we end up with a heat map like this that we can see here. And what we found that actually was a bit surprising is that a higher disorder or higher heterogeneity in the orientation of the collagen fiber is correlated with better prognosis. That means more disorder, the patient is going to do better. This was validated on breast cancer and also in oral cavity cancer. Finally, some closing remarks. First, AI is not sorcery. It requires to be thoughtful and intentional in developing algorithms. Second, AI plus routine imaging, for example, digitized tissue samples, can help to address questions in precision medicine, for example, predicting prognosis and therapy response. And finally, interpretability is required to facilitate clinical adoption. These are some next steps. We are working on developing novel image leverage biomarkers, developing pan-cancer models, and integration with radiomics and genomics. I want to thank the team behind the heavy lifting and you for your time. Happy to get some questions.
Thank you. Thank you very much.